So that's the source and quantum of funds. And again, the numbers I've used there are if we put this year's budget numbers into that framework. The other big change then comes with the funding flows. Now, the funding flows and how they work are of much more interest in Commonwealth-State negotiations, particularly amongst all our treasuries and the chief financial officers of each of the state health funding authorities. At the delivery end, the important thing is that is what money are you going to receive. But it is important to understand that there are some fundamental structural changes about the funding flows. First of all, for activity-based funded parts of what's going to be funded, the funding, both Commonwealth and state funding, will be paid into a national pool, a national funding pool, into a New South Wales account in that funding pool. The Commonwealth and state funding for in-scope block-funded services, such as small country hospitals, will be paid into a state-managed account, which will play the block funding. And then there will also be, the third element of funding, state-only funding, which will be paid direct from the ministry. The critical thing is that the state will advise the National Health Funding Pool of the price, the volumes, the block grant amounts to be paid to local health districts and networks based on the services agreements entered into between the ministry and local health services. So that the critical tool in all of this will be that service agreement, which will reflect the range of services and the dollars attached to those services in a very explicit way, as well as all the other policies and program requirements and so on that is appropriate in each state to reflect each state's health policies and health program funding initiatives. I don't expect you to take all of this in one glance, but it does create quite a complex set of funding flows. But as I say, if you're at the receiving end, the important difference will be that instead of your budget arriving in, once the budget's set and you're advised of it, it essentially arrives at districts in 52 equal parts once a week. In terms of your cash flows, it'll come in three components to make up that budget. There will be the blended Commonwealth and State ABF payment coming from the national pool, which is the blue box on the far your left. There'll be the component for block funded services coming out of the state managed fund, and then there'll be, as I said, the state only funds that flow from the ministry. The national pool is just a transactional hub. It requires legislation federally and in each state. The fund administrator will be a state person under state law, state auditor general, state direction for the state funds, at the same time as they wear the same role for the Commonwealth in respect to the Commonwealth funds. So it's quite a clever piece of legislation, but allows the funds to be pooled and allocated. But they're pooled and allocated in accordance with the specifications of the service agreement. And of course, in New South Wales, we started that service agreement model this year, so as a sort of a working model into which we can now put the activity-based funding. In terms of grappling with this whole concept about price, it's really important to understand that the pricing of services will operate at three levels. There's the national efficient price, which is what IPA is all about. IPA is independent and sets the national price. Essentially, the national price determines the Commonwealth contribution, because under the agreement from 1415, the Commonwealth is on the hook to pay a given share of that national efficient price wherever that lands, and that price will be a blend of the pricing all around the country. And of course all the states have different pricing. What it looks like when we mush all the pricing together for all the different types of care, we haven't seen those sorts of comparisons yet, because some of those models haven't yet been developed. But certainly when you look at admitted patients, DRGs essentially around the country, that sort of data has been around for a long time. So under those models, and we don't always compare apples and oranges, but Victoria is the cheapest. New South Wales is the next cheapest, and of the biggest states, WA is the most expensive. That's the sort of spread of, the cost of running our system. So the national efficient price will be a blended price, and on that model, we'll be on the cheaper side of the national efficient price. Then there's also, and probably more importantly in terms of what the district receives, there is the state price and the state funding model, because it's the overall state pricing that will and funding model that will determine what each local health district receives, and then the national efficient price contribution from the Commonwealth will be a subset of that. And then thirdly, there'll be local health district or network pricing, because each health service will have to organise how to allocate its funds. It will need to allocate out of those funds to overheads. It will then need to work out how it will fund each of its constituent hospitals and other services. If we take a district such as South East Sydney, and Terry Clout, the Chief Executive there, will be on the panel after morning tea. South East Sydney has been working with this kind of model for the last 3 years, so they're at quite a sophisticated level of development now in terms of that internal pricing and distribution model, and that's a model that they've developed in close consultation with their clinicians, with their board, and as I understand it, is a model that's well understood within that district. Across the board, we need to be developing and supporting the development of that capacity right across our system. Another important concept is this very new concept that appeared for the first time in the IPA determination, and I presume Tony at Sherburn will refer a bit more to this, is the National Weighted Activity Unit. What IPA is recommending is, and I think certainly we've written back supporting this approach, and we're endeavouring to put our funding model into this structure, is that we take the various elements of activity-based funding and put it into one single scale or classification system. At the moment, we've got acute admitted patients who've been long measured for a long time by Australian DRGs. We've got 2 different systems for large and smaller hospitals for measuring ED attendances. And there's a new and very fledgling measure for outpatient services as well. And what IPA is proposing is we blend those into a single unit. So we now have another acronym, the NWA, and that will become the unit that gets priced and which builds up the budgets. And I've just included a quote there from IPA as to how they see the potential of blending all of these things, and as we then start to add mental health and subacute and other things into this over time, that it makes it easier to look at substitution of services, or would we be better to buy this service here in this setting or buy it over in that setting, and to be able to see very transparently the different cost weights against those different models of care.